And so I'm going to start off just telling you a little bit about CaNIOS. And this is a small group, so if you want to interrupt and ask questions, I'm perfectly fine with that, so go ahead. And so CaNIOS stands for the Canadian Network for Improved Outcomes in Systemic Lupus Erythematosus. That's a bit of a mouthful, but it really says, it really does say what we are, and that is it's a group of Canadian investigators that are coming together with the intent to improve outcomes for lupus patients across the country through collaborative research. Now, why do we need something like CaNIOS? This microprint is not really meant for you to read. Let's see if I can make this. But this is a bunch of just random articles. Every lupus paper or book chapter that you will read, including I think everything that I've ever written, pretty much starts with something along the lines of, patients with lupus present in many different ways. It's a complex multi-system autoimmune disease. Disease manifestations are heterogeneous. Clinical presentation is heterogeneous. And then if you look at the bottom here, evidence suggests that the heterogeneity of SLE is a crucial aspect contributing to the failure of large clinical trials for new targeted therapies. I think you're all aware that we don't have a lot of new treatments for lupus lately, and there's a lot of things we're excited about, but it's really hard to get them going. And part of the reason for that is that lupus is so diverse and so complicated that, when I was doing my research training, I remember one of the professors actually laughing at us in one of our epidemiology classes because it said, you rheumatologists, you need to have committees to help you make a diagnosis of lupus, laughing at our classification criteria, because even to decide if a person has lupus or can be called lupus for research purposes, we have these complicated criteria that we use, and they're currently being updated. There's an ongoing effort right now to make new criteria that has been going on for several years, involves dozens of people internationally, and it's all to decide, is this even lupus? So that's how complicated it is. These are the old criteria that many of you might have seen. They are the ACR criteria updated in 1997. Again, I realize it's microprint. It's just a list of 11 different things with subcategories. And if you look at that, someone actually did the math, and there's more than 300 different ways that somebody could present and have lupus, meet these criteria, be called lupus. That's 300 different ways. And I think, as a group, you probably already have a good sense of that because you're all different from each other in terms of your lupus. But not only that, people with lupus differ from, one day to the next or 1 year to the next. So that means that it's an extremely difficult disease to study, and it really doesn't work very well if we're doing it alone. Even if we have a lot of lupus patients, and all of us, Anne sitting over there, and Deb and I, we have large lupus cohorts, meaning we have lots of lupus patients, 200-300 of them. It's not nearly enough, really, to get a lot of information because of this variety. So that was the reason for coming together. It was actually started way back in 1995 by Paul Fortin, who's now in Quebec. He wanted to run what's called a multi-center randomized controlled study of methotrexate in systemic lupus that had the acronym of the SMILE study. And again, we needed to get together. That was the first effort of getting all these centers across Canada together to do a study like this. And this study was actually funded by the Arthritis Society of Canada. And it brought, basically it brought all these investigators together who were able to pool information and pool studies, or pool patients, and that was the foundation for CaNIOS. So, it's a very loose sort of network. It's not like we do everything together. We also do our own thing, and we also affiliate with other people. But we've had up to 50 people across the country, and primarily in academic-based units, but also some rheumatologists, or some community rheumatologists, hundreds of patients. And as I said, it's been going on now for more than 20 years. So the goals are to facilitate the care of lupus patients, to improve outcomes in Canadian lupus patients, also to describe what does lupus in Canada look like, because that's got to be a foundation for any research questions we might have. And of course, to facilitate research in lupus and related diseases. And in order to do this, we need a large patient base to address these issues through research. So we also, Canada in a variety of ways is different, for instance, than the US. Our ethnic makeup is different, our healthcare system is different, and similar, it's different from Europe or other countries. So we also wanted to be able to look at subgroups of the Canadian lupus population, and that would include children with lupus, ethnic minorities, but also men, for instance. And for all of these things, whenever you're looking at subgroups, you need large groups of patients to be able to do that. And part of it also is that we are wanting to be able to provide mentorship to young investigators. We try to bring trainees and residents in so that we can continue this on over time. So actually, it was funny when I looked at my slides this morning, something had shifted and everybody had moved east. But it's back, I think, to more or less normal. So those are current CaNIOS centers. You'll see there are some gaps. We don't have the whole country, but we do have pretty wide representation in terms of areas that are participating in CaNIOS. And one of the things we notice if we know when we talk to each other and meet is that the patients that we see are quite different from one center to the next. For instance, London, Ontario will have a very different population than Vancouver or Winnipeg or Calgary. So the structure, as I said, we're all over the country. It's both pediatric and adult, and we have some associated members who are statisticians or methodologists or basic scientists, so they don't look after patients, but they help us with research efforts. And some of our studies involve all of the CaNIOS centers, and they're CaNIOS specific. And others involve only a few sites or selected patients. For instance, we may do a site, and I think we may do a study on pediatric patients, and obviously that is not going to include, I'm an adult rheumatologist, it's not going to include me. Or we may look at patients with kidney involvement or a certain subset, and so it doesn't always include everybody. In addition, as I said, sometimes we collaborate with others, so it'll be some CaNIOS sites and some people who are in different countries or not part of CaNIOS, and so it is a loose network to try to facilitate us all working together. And the foundation for this, though, is this national registry that we also have as part of it that I'll tell you a little bit more about. So some current projects that we have ongoing. Now this just came out. This is a project that is not a specific CaNIOS project. It was a Canadian project, involved CaNIOS centers, but also many other Canadian centers. And it was the project to develop Canadian guidelines for lupus, for the diagnosis, monitoring, and treatment of lupus. And so far, this was just published in the last few months. The guidelines for assessing and monitoring lupus has been published. And I think Stephanie Keeling in Edmonton is actually the head of this, and I think she's taken a big deep breath and sort of taken a breather before she hopes to move on to developing Canadian guidelines for treating lupus. And why do we need guidelines? They are helpful for everybody. First of all, and certainly patients can look at those and see whether, if there's something that's been missing in their treatment. But also, not everybody who sees lupus patients is a lupus expert. Lupus patients will be seen by community rheumatologists, by internists, by their family doctors, by other doctors who are all involved in their care. And these guidelines can help to decide what it is that we should, for optimal care, be doing in terms of looking after lupus patients. So this, again, was an example of a project that was CaNIOS, but also much wider than CaNIOS. And this project, I don't have to tell you very much about, maybe, because it's Anne's baby, Dr. Clark's baby. She has been championing economic challenges of lupus for a long time. And this, again, is not exclusive to CaNIOS. Dr. Clark has been working on this for a long time, looking, as I said, at what does lupus cost, not just in terms of medications and doctor's visits, but lost productivity, quality of life, all of those sorts of things, and has partnered with international organizations, but we have now also incorporated Dr. Clark's questionnaires and methodology into CaNIOS sites, so we can collect this and broaden this across Canada with Dr. Clark's expertise. This is something that just came out within the last couple of months as well. This is a project that was based on the CaNIOS registry. So this was only CaNIOS patients. We wanted to look at disease activity. Does disease in CaNIOS in lupus patients stay active? Or do they all become inactive? How many are active? That kind of thing. And this is based on our previous registry and involves close to 2,000 patients that, and I'll tell you a little bit more about that. And most of them had had disease at this point in time for quite a long time, for between 10 and 15 years. And there is this sort of concept or gestalt within the lupus community that disease activity sort of settles down and often goes away. And we were quite surprised that it was not as good as we had hoped. This is one example of a graph from the paper. So this, again, I apologize for the microprint. So this group of patients at the start of this analysis started out with moderately high disease activity as measured by the SLEDAI. It's just a measure of disease activity. So 100% of them, of these 442 patients, all had quite active disease. And then we look at what happened over 1, 2, 3, 4, 5 years later. And you can see that, so everybody starts out with active disease and then the next year it splits. So about 30% continued to have quite active disease. Another smaller group, about 10-ish%, got even worse, got more active. And then the rest of the group, about 20 or about 30% became, or 35% became inactive, which is good. And another percentage got a little bit better, but still had some disease activity. And what also, so it was just an indicator, okay, we've got a lot of people who still have active disease. And what's more, the majority of these people with active disease were taking steroids, or even those who didn't have active disease, they were achieving low disease activity with steroids, which you know is not really what we're looking to do. So the upshot of this analysis was that we have a long ways to go in terms of better treatment to improve disease activity and reduce steroids. The My Lupus Guide, I know that Calgary is a site for that, or was a site for that, correct, Anne? And so some of you may have already heard about it. This is, again, Paul Fortin's baby out of Quebec. And he's trying to develop a website that acts as, the initial name for it was the Lupus Interactive Navigator, and then it was changed to this as he was developing. He wanted a website that helped lupus patients navigate the healthcare system. And so that you could go to this website, learn about lupus, be directed to appropriate geographic or site-specific resources, so what's in your area, and empower patients sort of in their own care, so you would know what to look for, what to ask, and overall improve quality of life. And this is still ongoing. It's just been, the initial parts of it had just been developed and tested, and this is a project that's still ongoing, and Anne is going to be participating, so some of you might be getting or have already been asked to participate as well in testing the website and using it from there. This is also a method for communicating information. We hope that the Lupus Interactive Navigator will be a way to disseminate relevant lupus information. And CaNIOS was able to reach, I think, 1,900 patients to ask them to participate to test this project. So that was something that, because CaNIOS had all these patients in our registry, that was able to facilitate this particular project. Another project that is ongoing right now is called Hydroxychloroquine and SLE. Dr. Glenn Hazelwood, whom is a Calgary rheumatologist that some of you might know, along with Dr. Sasha Bernatsky in Montreal, are the principal investigators for this. I'm not sure how familiar this group is with the controversy or the current issues with hydroxychloroquine in lupus. it is our background drug. Sort of the gospel of lupus is that if you have lupus, everybody should be on hydroxychloroquine from start to end forever. That's kind of the way, you know, lupus management is currently stated. And obviously that's easier said than done. There's many reasons why people may not be on it. But what's happening as we use this as a long-term drug, we're developing more toxicities of hydroxychloroquine. So we need to understand who's at risk for toxicity, how do we avoid toxicity, and what happens if we reduce the dose or stop the drug? What is the risk of flare or disease? So this is a huge issue that is the subject of lots of debate and meetings. And Sasha and Glenn are trying to understand this, and they are using a combination of the CaNIOS cohorts to look at where we have already recorded, because we've been following people who are on hydroxychloroquine, who've stopped it, who've changed the dose, and who've possibly developed toxicity. And then they're also going to have, they really want to understand, well, what do patients, you know, what is the patient preference? What is the patient understanding? How does the person with lupus feel about being told, okay, here's this drug that you must take. It might cause eye problems down the road, but if you don't take it, you know, things are going to be worse. Like, these are all very complicated things, and they're trying to understand, well, what information do patients need? What do they feel? So this study is then going to use the CaNIOS data. It's just starting up and running now. It's going to use the CaNIOS data, and then going to move into more of a qualitative focus group sort of aspect. And the intent of them is to use the My Lupus guide that I just told you about to disseminate and try to get some of the patients to get some of the ideas when they get to more to the focus group aspect. So you can hopefully start to see how this is all interacting and meshing as a network. And this is another study that's just going on. Dr. Lily Lim is a pediatric rheumatologist, and she is very interested in what happens to children and young adults with lupus in terms of their employment trajectory, their education and employment. How does this impact on their future employment? We all know that your education and employment, I mean, that's the foundation of what kind of a life you're going to have, essentially. So she is starting off using the data set that we have, which, you know, is about 2,000 odd patients, including young adults and children and adults with childhood onset lupus, and to look at, and we do collect data on employment, and so she is going to look at that and see what information she can describe about what happened to these patients in terms of their employment. She also has a portion, she's doing the same thing, a related thing. In Manitoba, in Alberta too, we have what was called administrative data. So that is data every time someone has contact with the healthcare system that is recorded for billing purposes, essentially, in government data sets. Those data sets can be used for research as well. And they're anonymized. I mean, everybody's just kind of a scrambled number. There's no personal information given out. In Manitoba, there are standardized educational tests that kids do. I think they do them grade 12 and grade 6 or grade 9. I don't actually know, but Lily does. And these standardized scores are actually linked to the health database. So you can link health outcomes and, you know, educational scores. And Lily, as part of this, she's also looking at that to see, you know, what happens with test scores, and then how does that relate to health and to lupus and other health outcomes. And her ultimate goal is to take all of this and then develop what she called a prospective study, so not looking backwards at data, but actually asking young adults or children or young adults to participate and follow them along and see what happens. Because the ultimate idea here is to find out, well, how do we need to support children and young adults in achieving educational and employment objectives that they will have. So that's something that's ongoing now. She's just starting on as well. So, and then lastly, there is, because of CaNIOS was invited, or CaNIOS centers were invited to participate in something called the Lupus Clinical Investigators Network, and I know Calgary is a site, Dr. Clark is a site for that as well. And it's an initiative sponsored by the Lupus Research Alliance. It's a big lupus foundation in the US, and it was kind of Peter Lipsky's baby. And the idea here is to be able to facilitate clinical trials of diverse and novel interventions. Everything from nutritional supplements. There's a free fatty acid supplement study that I think has just started going on, as well as new drugs, to psychological investigations. And because everybody is working together, and this one of course also involves, I think there's 53 sites, Lucent sites altogether, and maybe 8 of them are Canadian, something like that. The rest are US. But we're able to try, the idea is to really effectively and quickly try to understand or develop new interventions for lupus. And this has been, I think, pretty successful so far, and is exciting for us as well to be part of that. So the foundation of everything that we do that sort of allows us to branch out into these other things is the registry. And that the registry is the goal is to provide a snapshot of lupus in Canada and follow lupus trends in Canada, so we can see, what's changing. Are we seeing, more children with lupus, more ethnic minorities, more men? What's happening in different? We can do all that if we're collecting this data. And as I said, the major goal is to facilitate all of these other studies. What it lets us do is somebody comes along and says, hey, I have this idea for a study, whether it's a drug company or whether it's Dr. Clark or Dr. Lim or somebody else, and says, I want to do this study. And well, what do we need? And we need this. Okay, well, how many young adults with lupus do we have? How many people in these centers in this age group, or how many people on this particular drug do we have? And we can sort of get things together fairly quickly, and we have this built-in established collaborative network that facilitates that. So that's what we're trying to do with CaNIOS. So basically what happens with the registry is that people who are attending their usual lupus clinic visits at CaNIOS centers are asked if they want to participate. And you get asked to fill out questionnaires. And we also fill out questionnaires, or surveys on these are instruments that we use, sort of standardized instruments to record disease activity. For instance, how active is this person's lupus today? Also things like what clinical manifestations do they have? What treatment are they on? Of course, that's very important to collect. And what complications or damage do they have? Patients will be asked about quality of life, and about work history and health-related behaviors like smoking and exercise and healthcare utilization and things like that. And we still are doing it on, we're still doing it on paper, which is mostly someday we would like to be able to hand people a tablet and do it more sort of new 21st century, but we're not there yet. So the other thing is that we also we do routine blood work that you would have anyway as part of your lupus visit, but many sites will also collect DNA and serum and urine that can be used for research purposes. It can be stored and used then, so then we can coordinate the two. Doesn't affect treatment decisions. This is all routine care, so whatever you and your doctor, the person and their doctor decide they're doing, that's what we do. It doesn't schedule extra visits. It takes, of course, a little bit of extra time during that visit to fill out the questionnaire, and potentially an extra vial of blood or two. But it is real-time observation. That's not what I wanted to do, sorry. Real-time observation of lupus patients. If any of you have had experience of being in a lupus clinical trial, for instance, where you're enrolled in a study of a specific drug or an intervention, it's very rigid for necessary reasons. It's very rigorous in terms of who's eligible and who's not, and when you come, and all of the, and the treatments and all of this. This is meant to be more real world. These are lupus patients. This is the way they're treated. This is the way their outcomes are, and so that we can get an understanding of what's going on in real time. And of course, it's anonymized. I mean, we're not recording names or identifiers. People get assigned study numbers, and everything is sort of recorded under that. It is web-based. We do enter it into a web-based platform which allows us the flexibility, for instance, to update it. We can add new medications as they hopefully become available. We can add new forms as new measures become important. For instance, we added the healthcare utilization forms that we thought were important to do. So we can, having it as a web-based platform allows us to do that. So in this new web-based platform, as of 2 days ago, we had 650 patients across the country enrolled. There is an older data set that we're in the process of doing the computer programming to stick them together. That to amalgamate the two, it was on a different platform. That one had close to 2,000 patients, and some of them are still part of this, so we would have more long-term data. And this is sort of, we've had this new database just for a couple of years, and so it's growing by leaps and bounds and becomes more powerful the more people are participating and the longer we have follow-up. So we're pretty excited about that, and Lupus Canada has been very generous in helping us to get this going. So as I said, you get these questionnaires that look kind of like that there's one for the patients, and one for the docs. And then what we can do with it, as an example, is you can get an overview. This is just a snapshot. How many of the lupus patients that we have arthritis? Well, 81% do. How many are on a blood thinner? 15%, that kind of thing. This is just very simple kind of information that we can get as a snapshot of to figure out what's going on, or if anything has changed, or what kind of studies we can do. And we can also look, this is a measure of damage. Damage are considered permanent. It's a lupus term where we're talking about permanent consequences of either lupus or its treatment. So that would be if kidney failure is one certain permanent consequence, or a fracture because of prednisone would be a permanent consequence of lupus. So we can measure how many people have no damage, and in this was 800 people. This was about, so it was 1,700 people, and about half didn't have any damage, which is great, but some did have damage scores. So we can sort of look at that and see where we're going and what's changing over time. This is a measure where this is getting now a little bit into some of the ethnic differences. This is looking at how old are people when they first get lupus. And this is 3 ethnic groups. This is Asians, Caucasians, and this is Indigenous people, and the name got left off. You can see that there's for Caucasians, there's a very broad range. Most people are diagnosed sort of this is 20 to 40 years. The biggest hump, so to speak, is there. That's the most common age of diagnosis. Look down here for the Asians, we have a very high frequency of diagnosis in childhood or young adulthood. And for our Indigenous patients, it is again more evenly distributed. So we can make some quick comparisons like that. And we can also look at factors that might influence disease activity. And the main thing that came out of this was that current smoking unfortunately made disease more active. And we can look at that as well. And this was another example how if we're trying to understand kidney disease, that the younger patients are essentially when they develop lupus, the more likely they will have kidney involvement, which is one of the more feared complications of lupus. And Dr. Levi will be probably talking about that. I mean, probably the majority of children with lupus do get kidney involvement, and that gets much less for people who develop lupus later in life. So basically, that is what we're trying to do. We are trying to collaborate through research to make research more effective. And this gives us a built-in sort of network infrastructure to do that. And that was the end. I don't know if anybody had any questions about the CaNIOS, or if you want to leave it till later before we move on to the next part. Okay. So this is then moving on to research and clinical experience with our Indigenous lupus patients. This is a slide that I borrowed from Liz Ferrucci. She is a rheumatologist in Alaska, and who works for the Tribal Health Council there, and her patient population is pretty much exclusively Indigenous. And what does it mean to be Indigenous? Lots of different ways of identifying that, and it's fairly fluid and it varies. For all of our studies, we've used self-identification. It's that a person will identify as Indigenous, and that is, it's not a genetic test, it's not of parenthood, it is a self-identification. And all of these, and of course it can be a political designation in terms of having status as a First Nations person in Canada, or there's a similar designation in the US, but it is primarily a cultural history or cultural identity. And so that's also the definition that we have used. So there is pretty reasonable evidence that lupus is more common in Indigenous patients. I don't know if you were aware of it, but the Center for Disease Control, the CDC in Atlanta, has become interested in lupus, which is a bit strange, but good. They are known, of course, for looking at epidemics and infectious diseases, but they're also now looking at public health issues, and they've recognized lupus as a public health issue. So they are actually looking at how common is lupus and branching out from there. So this slide this graph is from a guy named Peter Ismerli, who is working with the CDC and looking at the prevalence of lupus in different areas in the US. And Liz Ferrucci was involved in this as well. And so so the different colors are different parts of the US, and then these are the different ethnic groups. And you'll see this is Black US people, and nobody's quite sure why there's this spike in California, but you can see that lupus is more common in Blacks compared to whites. This is overall, this is white, and you see Black is about twice as common. Asian and Hispanic are also higher than whites. And this here is American Indian, Alaska Native, so this is US Indigenous data, and you can see that it's an extremely high frequency of lupus. We had found in Manitoba, I had done the same thing, and lupus in Manitoba is at least twice as common. When I had done a population-based study, and that's like 15, 18 years ago, it was about twice as common. At that time, we had much more healthcare access issues than we do now. It's gotten somewhat better. So the only lupus that we were seeing was sort of the very severe lupus patients, and now we are fortunately starting to see some of the milder lupus patients as well. So the evidence is now it's probably 2 or 3 times as common in Indigenous Manitobans compared to other Manitobans. One of the things that's very important to know is that it's not the same for everybody, and for a lot of groups we don't know what the answer is, but Indigenous groups are extremely variable, and so this may not apply to everybody. This again is US data. It's a little bit older, and the only point of this slide is you can see that the incidence, this is how many develop new lupus, varies, like it's 1 to 3 times here. So it's not the same in every group, and some groups may have a lot of lupus and some may have not so much, and we're missing an awful lot of information, frankly, about that. So, but it isn't a one-size-fits-all issue for sure. So is there anything different about lupus in Indigenous populations? They do have a younger onset age. Now this is not that unique. That seems to apply to every non-white population. It is very well described in lupus that on average, lupus in white people is not as severe as lupus in all other ethnic minorities. And part of severity is developing it younger. The longer you have to live with it, the more it interferes with your life, the more time you have to develop complications of lupus or its treatment. Obviously that makes it more severe. So as I said, we do have a younger onset age, but that isn't all that unique. We do have a lot more autoantibodies. The titers of ANA, you're probably all familiar with the anti-nuclear antibody. The levels are often higher. There's more antibodies, particularly RNP. one particular antibody that seems to be associated with myositis, which is muscle inflammation. It's not otherwise one of the more common lupus manifestations, but it is certainly well recognized, and we see quite a bit more of it. We see a ton of arthritis. I've never seen an indigenous lupus patient who does not have significant arthritis. And it is a very common presentation and often a misdiagnosis because the overwhelming, all they have is arthritis. They don't have any of the other features we commonly look for, rashes or kidney or heart or lung involvement. So the lupus diagnosis is sometimes very delayed because it's not recognized that it's lupus, because it's only arthritis. And that has led to some very unfortunate complications, because then it isn't recognized, it isn't treated as lupus arthritis, and then they do develop other issues. So seems to be a higher frequency of arthritis. I mean, arthritis in lupus is of course very common, but it's not quite this common. And overlap syndromes, that's when someone has lupus but also has features, let's say, of rheumatoid arthritis or scleroderma or other sorts of autoimmune disease. And both in Manitoba, but in several other Indigenous populations, it's been described that there's more sort of overlap as well. And again, that points to severity. So knowing this, we wanted to look at outcomes in lupus and compare that between the different ethnic groups. And I know this is a difficult topic for people with lupus, but one of the focuses here is actually mortality or premature death, and that is because it was our clinical impression that we're seeing way too much premature mortality in our Indigenous population, so we wanted to try and figure out what was going on there. And I do know that that's not an easy topic to hear about, but it's still, if we're going to change it, it's important. So this is all relates to Manitoba, and Winnipeg is kind of weird when it comes to lupus and rheumatology, because everything, if you think of Alberta, you have two major centers and things are split a little bit. In Manitoba, Winnipeg is the only major center. That's where all the specialists are. And the Health Sciences Center where I work is sort of the tertiary hospital. So we have this huge funneling effect. Everything comes to Winnipeg sort of from the entire province, and it does make it very tertiary, and meaning sort of very severe end of the spectrum. It also gives us some research capacity, though. And because of the brainchild of one of my colleagues, we have sort of been entering all of our patients that we see since 1990 into a database so that we know who our patients are. And that has allowed us to really do some research we wouldn't have otherwise been able to do. Because when I started this particular analysis, just in our own center, we were able to look at 881 patients, which is a pretty decent number to try to get some information about. And 25% of those patients were Indigenous. And the majority of these were of various Asian backgrounds. That's our other largest ethnic minority. And over these years, now this goes back over, since 1990, 18% of them were deceased. So this is where, so when we compare these groups, this is where you can see how they are, both Indigenous and the other ethnic minorities start disease earlier. Then also you can therefore, when the last time we see them or is also younger and they have less disease. But if you look down here, 17% of our Caucasian patients had died, only a small percentage of our Asian populations because they were quite young, but more than a quarter of our Indigenous patients over that time had already died, even though they were not that old. And that's just a percentage, and we're going to look at that a little bit more. The other thing that is really important to look at is things that affect, we call them the social determinants of health, which most people in medicine realize are much more important to health than doctors or medications. It's really, what are your social circumstances that you live in? Our high school completion rate for our Indigenous patients is only 40%, and this is actually the Canadian average. So, only 40% of our Indigenous patients are even getting to past or getting to high school. Now, the other thing that is unique to Canada, to places in Canada, is the long distances patients have to travel. And that's certainly true for Manitoba because, Winnipeg's in the south. And so 30% of our Indigenous patients had to travel more than 500 kilometers to see us. And another close to 30% had to travel, somewhere in there, long ways. And really, this is not so much the case for our other non-Indigenous populations. Now, that travel is funded, but the complexities and the time that it takes for them is very difficult. So that's a uniqueness for our Indigenous population. And then we have income. This is based on StatsCan household income quartiles and just sort of based in the quarters of income. And basically, fully or close to half of our Indigenous patients are poor, compared to a much lower rate of our non-Indigenous patients, and very few are in the higher income group. So all of these things, affect health in a variety of ways. So this just again is to show that we talked about that a little bit in terms of differences. A lot of kidney involvement, particularly in the other ethnic groups, but also in the Indigenous patients compared to white patients. Kidney involvement is one of the worst complications of lupus, as that you might know, and strongly related to outcomes later on. Again, here's the arthritis outcome that we talked about. And we have sort of mouth ulcers and sun sensitivity. Those seem to be more common in white patients. So the other thing we found when we were looking at, well, why were people dying? We have a high, we don't know, because our Indigenous patients, if they're not near us, we often actually don't know what happened. But when we do, we found that lupus was the direct cause more often. And versus our white patients who were surviving longer and were more likely to live a longer life and develop heart disease or cancer, and compared to both of our minority patients groups. So this is a survival curve. I don't know if you've ever seen these before. Over here is survival from diagnosis in years. That's the time of diagnosis. This is the 0 line, and this is 25 years out. And so obviously at the diagnosis, 100% of people are alive. And over time, some people, people gradually will pass away, either from lupus or other causes. And I mean, you don't need me to tell you that there's a clear difference here in this line, starts separating out and falling off very early. Even at 5 years, you're seeing, 5 years into diagnosis, we're seeing a big difference here of poor survival in our Indigenous patients. Whereas the Caucasians and the other ethnic groups, that's sort of an overlapping, there's no difference there in spite of young. Remember that the Asian or the other ethnic minorities also had a young age of onset and had lots of nephritis, but we weren't seeing that difference. You might have heard of survival rates in lupus. We used to talk about, back in the 1950s, 5-year survival in lupus with 50%. That means that 5 years in, half of the patients didn't survive past 5 years. Nowadays, 5-year survival is well above 95, close to 100% in the Western developed world. And in fact, that's what we see. 5-year survival was a 98%. And even 15 years out from diagnosis, it's still 89%. Keeping in mind, though, that that means we are still losing 10% or so of patients, and these are young people. People develop lupus at 35, 40, so 15 years in, they're 55. Losing 10% is still bad, but it's so much better than it used to be. But here, there's a huge difference all the way through in our Indigenous population. Another whole 10%, 20% of patients are not making it to 15 years, even though they're being diagnosed at a younger age, so they're dying even younger. We looked at a measure called potential years of life lost, which basically is a measure that looks at, it weights deaths, because someone who is dying at 50 has lost more potential years of life than someone who dies at 75, essentially. It's not a one-to-one in that sense. So weighting that, it basically just, it's just a statistical measure, but we're seeing a lot of premature deaths in our Indigenous population. That's what that's telling us, a much younger age. So then we looked, okay, well, what impact does something like education have on mortality? Like, what's going on? Remembering the social determinants of health. So this is looking at all of the patients and separating those that had graduated from high school or who had not. We didn't have any better measures of education, like we didn't have enough to do more than that. But you can see a very clear early separation here, that there was a very clear impact of lack of education increased your risk of dying a lot. And similarly, this, for those who hadn't completed high school, survival rates were overall lower, and potential years of life lost were much higher. So lack of education was a major player in mortality or in premature death. Similarly, income as well played a role. This is the highest versus the lowest, and you can see the separation hopefully there. So being poor also impacts on, increases your risk of death. Now, this is one of the ones that's a little bit unique, because this isn't something that many centers have. So this is distance to rheumatology care. That's not what I wanted to do, sorry. So here, those that you can see, this one isn't quite so bad, but you can see a clear separation. Those that are very remote from care, again, that has an impact on mortality. And this is probably worth talking about, because it's more than just distance. Everybody here has had to go to a doctor's appointment and tried to figure out time, when am I going to put that in my day? Well, imagine if it's a 3-day extravaganza. You've got to fly down one day and you spend your 20 minutes with your doctor, and then you fly in the next day. How much disruption that is to your life, childcare, your work, everything else. Of course, there's a million reasons then why that visit might be canceled. Bad weather, we live in Canada. Couldn't be one, that you could miss that visit. That's a possibility, and travel arrangements get screwed up all the time. But it's also for people, there's also other things going on in remote communities that we are capturing in this measurement that has more. It's not just a distance measurement. There are clearly other aspects of life that are going to be different if you live in a remote community, not just how far you have to travel. So this was something that we were able to show, that was playing a role as well in terms of impacting survival. So this is a bunch of statistics, but when we also incorporated into statistical models, if we look at, if we account for disease severity and age, and whether they have kidney disease and all these other things, what sort of impact are these different factors having? So in these separate models, what this is telling us at the top here is that Indigenous ethnicity just being Indigenous increased your risk of death twofold, all other things being the same. Similarly, not having a high school degree was about 1.9, or twice the risk, increased your risk of dying from lupus by about 2. Similarly, living from a remote access, close to twice the risk, and being poor, a little bit more than twice the risk. So all of these play a big role in what's going on. And and keep in mind, when you look at those, that the people who hadn't graduated from high school, the people who were poor, the people who were living far away, by and large, those were Indigenous people. So all of these things are interacting together to impact on outcomes. And when we put it all together, really, Indigenous ethnicity was still the top ranked. There's something else going on beyond disease severity and beyond these things we can measure. And part of it is our measurements aren't very good. I mean, as I said, high school graduation isn't the best measure for education. Income, we only have a certain amount of time, certain point in time. So these aren't great measurements, but there is still some aspect of being Indigenous that was playing a huge role here in outcomes. So we wanted to look a little bit, because there's so much nephritis in these populations, we wanted to look at that a little bit more. And you'll see there's a few more patients because this analysis is a couple of years further on. Similar here in terms of 25% of our patients were Indigenous. And huge differences in the amount of kidney involvement. About 57% of our Indigenous patients have kidney involvement. 3/4 of our Asian patients have lupus nephritis, which is really huge. Okay. So that means your odds of having kidney involvement compared to white people is twice the odds for Indigenous and almost 5 times the odds for Asian patients. And similar here, that young age of diagnosis for Indigenous and Asian patients. And this one was interesting, that in spite of all the kidney disease and the young age, damage scores were low for Asian patients. These are outside of renal damage scores. So for some reason, outcomes in this group were actually better, which is... So then similarly here, this is the same group, and you'll see the exact same things, that we're having low high school completion rates, lots of patients living far away, and lots of people in the low income group amongst our Indigenous patients, same sort of thing. This slide is only here to say the outcomes are not seemingly related to lack of treatment, because what you'll see, they're all treated at the same center, and those patients with more severe disease were treated more aggressively, as you would expect. So although there's lots, we don't have a good idea for treatment, it's not simply that they're not getting treated. There may be patients out there that we're not even seeing, but these are the ones that we are seeing at our clinic, and they are being treated. So, and this is again, these are, what is the risk of, if you have kidney involvement, if you have lupus kidney involvement, what is the risk of end-stage renal failure? That's when you need to either go on dialysis or get a transplant. And we found that risks were much higher for Indigenous and Asian patients, about 4 to 5 times as high. Here, education had no effect on your development of end-stage renal failure. And income and proximity care did not have any effect. There was, in this, it didn't impact on progressing to end-stage renal failure, which is different. However, for those patients that did develop kidney disease, again, these same things, risks of, so these are patients who all have kidney disease, and Asians have more kidney disease, but the mortality rate is not different. But again, we're losing our Indigenous patients. And here, education does play a role in that, and so does income, and so does care proximity. When we put it all together, high risk of renal failure for Indigenous and Asian patients. But in terms of the major player here for patients with renal failure was education, and a little bit of a signal from income, that those were the major players in terms of premature death, that they were much more important than anything else. So, to summarize this, we have lots of nephritis. Asian and Indigenous patients had more risk of developing lupus nephritis and more risk of progressing to end-stage disease. And this was not impacted by income or education or living remote from care. That didn't seem to impact on whether or not people developed end-stage kidney disease. But all of these things did increase the risk of death in these patients, except that Asian patients who had the highest risk of end-stage renal disease didn't have an increased risk of death, while for Indigenous patients it was also almost 3 times as high. And again, keeping in mind that our Indigenous patients are overrepresented in low education and low income groups. So I'm digressing here because very similar findings were found in the States. This is a study of Medicaid patients. So 42,000 something lupus patients. Okay. And this is the title of the paper, Racial Ethnic Variation in All-Cause Mortality in Medicaid Recipients. And they called it this Hispanic and Asian paradox because previous research has shown such severe disease, and yet when they looked at our mortality compared to whites, here's a low risk, a much lower risk. But for Native Americans, again, a high risk of mortality, even though disease seemed to be, in both Hispanics and Asians, disease seemed to be worse, but this group had a higher death rate. So we're not alone in that. That finding has also, this is a different study, but we're not alone in that. So ultimately, so what is this telling us? So we're looking at potentially more important biologic or genetic role for developing lupus nephritis or lupus or severe lupus, and for progressing to end-stage renal disease. But sociodemographic factors, the social determinants of health, are playing a bigger role in terms of premature mortality in lupus. So, just to finish up, what's possibly influencing epidemiology here is genetics. There have been some increased, there's many genes that are involved, have been shown to be involved in lupus risk, and everybody's genes are different, which is why everybody's lupus looks different. And they're not necessarily abnormal genes, they're just coming together in a way that's problematic. Some studies have shown increased frequency of these genes in people with indigenous ancestry. Some novel genes have been identified. But environment is really important as well. Tobacco exposure is one. Unfortunately, both here and in the States, probably the highest smoking rates that we have are in our indigenous patients, and smoking is known to both make lupus worse, but also bring lupus on, plays a role in that. There's other, uranium, silica, being near mines, these things, there's also been some signals that this is going to play a role, and that's more common in people, in indigenous people. But other environmental things are also, we are increasingly learning that major psychological stressors and trauma precipitates disease later, especially and particularly autoimmune disease. And a study that was just presented, I don't know if anybody's familiar with the Nurses' Health Study. It's a study that's been going on in the US since the 70s. They have been tracking more than 200,000 white nurses. And so this is huge, and it's been really useful study to look at a lot of things. And they have recently, there's a researcher at Harvard by the name of Karen Kostenbader who's been looking at lupus in this group and what contributes to lupus. And just out is that they have looked at childhood psychological trauma and found that it increased the likelihood or the incidence of getting lupus as an adult. And there's other studies suggesting that as well, also that it then makes lupus worse or more active, harder to control. So knowing that, we don't have the data in our indigenous population. The research has not been done, but that's not what I wanted to do. So it would be, a no-brainer really to assume that colonization, residential schooling, racism is not having an effect in both bringing lupus on, but worsening the outcomes for our indigenous population. And this is something, and not only lupus, of course, but many other health issues as well, and that this whole issue is probably playing a huge role in indigenous health. And we don't have that yet. That research needs to be done. We can assume it, but really in order to deal with it, it is something that we need to know more about. So I think it's really important to recognize that most doctors do. I mean, we know that it's actually really funny when we go to American meetings and they talk about fixing healthcare. They think we have all the answers because we have public health, which we all know is not quite true. But they are, you know, they'll talk about, well, how can we fix things? Well, you know, well, vote Trump out. We get these, it's a very interesting dynamic there. So most of us know that we need to recognize this, and if we could improve on these measures, of these social determinants of health, health overall would improve. This is, I know I'm just about out of time here, this long distance care thing is actually really tricky because it's much more than outreach clinics and telehealth. Telehealth is great, but it's not the same interaction as if you're face-to-face with your doc. I know Liz Ferrucci in Alaska, she does a mixture, and that is probably a good way to go. She sees her patients sometimes face-to-face, sometimes by telehealth to minimize travel. We do outreach clinics. We're limited in resources because there's so many places to go. But we have noticed, I don't think they've published it yet, but one of my colleagues looked at a study and found that, or studied it, that attendance at clinics was not necessarily better in the community, like rheumatology clinics, than when we have them come to Winnipeg. There's clearly more going on in terms of trust and capacity and other emotional or other issues that are going on. So outreach clinics are not really the only answer, although they're certainly part of it. And, you know, I said we need to really understand what impact this has so that we can all recognize this and try to deal with it. And then I just wanted to acknowledge all of my funders, but also all of my colleagues without whom we wouldn't be able to do this. And that's it.